So Dr. Governor, Dr. Vandale, I wondered if we should just wait a minute or two, or we could just start and people will join in. We have quite an interest in the topic, so we just hope that as many people do join in. What do you say? Would you like for us to begin now?
No, we can wait a bit. My presentation is not long, so
Okay, we can wait.
we can wait up to 5 minutes even now.
So, uh, okay, if you can just hold on with your slides, I'm just going to just do a brief introduction, all right? So, good afternoon, colleagues, and welcome to the UKZN Echo Outreach Platform. I'm Cyrilla Ramklas, and I am the manager of the Echo Outreach for the School of Medicine at UKZN. So this platform is a collaboration among the School of Medicine, the KZN Department of Health, Echo India, and the Echo Institute at the University of New Mexico in Albuquerque. So this collaboration enables specialist faculty from the School of Medicine to exchange knowledge with healthcare workers within KZN and beyond to improve patient outcomes and quality of life. So today's session, titled Esophageal Cancer, is hosted by the Department of Surgery at UKZN. The session will be led by Dr. Mogi Govender, who will chair the session. Before I hand you over to Dr. Govender to present an overview of the session, allow me to share points on video conferencing etiquette. So please ensure that your name is visible in the participant list on Zoom. Keep your microphone on mute when not speaking. Raise your hand or post your questions in the chat during the Q&A. I hand you over to Dr. Govender, who will present an overview of the session and introduce the presenter, Dr. Vandale. Thank you, Dr. Govender.
Thank you, Dr. Ramklas. Good afternoon, everyone, and welcome to this afternoon's ECHO presentation on esophageal cancer. Esophageal cancer is a devastating disease. It is the 7th most common cause of cancer globally, and it is the 6th most common cause of cancer-related deaths worldwide. So it is quite an aggressive cancer, and it is endemic in parts of South Africa. So we have a particular interest in this problem. Today's talk is aimed at clinicians of all levels, and the focus is not just on sharing information, knowledge, and raising awareness, but on encouraging earlier referral of these patients and ultimately to improve outcomes. It is my pleasure to introduce this afternoon's speaker, Mr. Lucian Ferndale. He is an upper GI and HPB subspecialist surgeon at Gray's Hospital and a lecturer with the University of KwaZulu-Natal, and he has a special interest in the research of and management of esophageal cancer. I hand you over to Mr. Ferndale.
Thank you very much, Dr. Govender and Dr. Ramklas. Thank you. Let me put my video on just so you can see me. Oh, not working really. Okay. Anyway, so today's talk is going to be basically a contextualized practical approach to esophageal cancer. And I'm specifically going to just highlight the challenges we face in the area that we work here in KZN. And maybe present some ways in which to improve things. And it's not a long talk, so there will be plenty of time for discussion afterwards, and I hope that that my talk will stimulate quite a bit of discussion. Now, I'm going to start with a case presentation. So, this patient presented to us a 58-year-old female from a regional hospital with no comorbidities and a history of dysphagia for 1 year. Associated with weight loss, and she was treated as a patient with peptic ulcer disease. She was sent to a regional hospital 2 months before coming to us, where they performed an endoscopy and found a tumor at 25 centimeters from the incisors, and they were unable to pass. They biopsied it, and the histology of that came back as a squamous cell carcinoma. When she came to us, we noted that there was nothing more in the history apart from the history of dysphagia and weight loss. She had temporal wasting. Her weight was 46 kgs at the time, and that gave a BMI of 17. ECOG performance that was 2, and albumin was 24. This is just a reminder to those who don't know that the ECOG status is a validated performance status measure used for cancer patients. And 2, as you can see, means that this patient was ambulatory, capable of self-care, but unable to carry out any work activities. And when we asked them any work activities, including work around the house and the garden, etc. So they can't do any of that. But they're not bed-bound or wheelchair-bound. In other words, more than 50% of the waking hours they are moving, they can move. Okay, on endoscopy, this is the picture on the left is what we first encountered on entering. And as you can see, there is an obvious tumor in the esophagus, and there's no lumen to pass the tumor. The picture on the right shows the same tumor, but now you can see there's a guide wire that's gone through it. So what we had done at this point is we had passed the guide wire, a salivary guide wire without fluoroscopy, and then dilated the tumor, and we managed to get past it and measured it, and we saw that the distal end was at 35 centimeters, so we measured a 10-centimeter tumor, and this picture is taken after that was done. Hence you can see the blood. For a number of reasons, we decided that she was for palliation, and so we inserted a stent, and the stent we insert is our self-expanding metal stents. As you can see, the picture on the left, the delivery system is still inside, and stent is being deployed. And in the picture on your right, you can see the stent is being deployed. So these stents, they are self-expanding. The more proximal bit that you can see here is uncovered and can manage to grip the tissue, whereas the bit in the middle is covered and avoids tissue ingrowth, and so it avoids the tumor from obstructing the stent itself. Further management for this patient was we gave her analgesia, we gave her morphine, that's what we normally give together with paracetamol. We give our patients all omeprazole for reflux symptoms. We refer them to a dietitian. Now, the dietitians have a lot of experience with these patients, so they mainly give them dietary supplementation. And knowing that these patients cannot eat normal food, their food has to be a soft diet, liquidized, etc. So the dietitian, maximizes their calories. And then they were given best supportive care, which I will go into what it means more when I discuss this case. So on the topic of esophageal cancer, what is it? It's a cancer that originates in the esophageal epithelium. There are 2 main subtypes, as we know, squamous cell carcinoma and adenocarcinoma. And the incidence, the latest incidence, and if you take all cancers, it's 11th most common cancer and the 7th cause of cancer mortality. You can see by that figures that it is a highly fatal cancer. The other thing about incidence to remember is that squamous cell carcinoma makes up 90% of cancers worldwide. Adenocarcinoma only 10%. I highlight this because it is easy to think that adenocarcinoma is more common given the way the literature on the topic is presented, but it only makes up 10% of all cancers worldwide. The other peculiarity with the incidence is that it's a geographical concentration of these cancers in certain areas in the world. And this incidence map, which shows the incidence of cancer where the darker bluish areas have got a higher incidence. You can see there are 2 major high incidence areas, one in Asia, which is called the Asian esophageal cancer belt, and a second one in Africa, which is called the African esophageal cancer corridor. Now, the Asian esophageal cancer belt is well known and described in many papers in the literature. The African esophageal cancer corridor, though, is not. Fewer people know about it, but it extends from Ethiopia to South Africa. So South Africa lies within it, and it's all along the east coast of Africa. So there's hardly any esophageal cancers in the west part of Africa. Okay. The clinical presentation of esophageal cancer, it makes the diagnosis actually not very easy. And this is one of the reasons why these patients present so late. Now, dysphagia and weight loss are cardinal symptoms. Patients present with those two symptoms, then this is esophageal cancer until proven otherwise. They are also considered alarm symptoms, so any patient with these two symptoms should be referred to exclude esophageal cancer. It already means locally advanced disease. In other words, you can't pick up an early cancer if the patient presents to you from clinical symptoms of the cancer itself. The examination is unremarkable, except for evidence of weight loss usually. And the take-home message for the day must mean that I wanted to emphasize was that dysphagia must equal endoscopy. Barium swallow, which has been used in the past as a workup, part of the workup is no longer part of the workup algorithm for esophageal cancer, and it is no need for it at all in this workup patients, provided they can get an early endoscopy. As I mentioned, the endoscopy biopsy is the main investigation of choice. If you are in an area where you can scope patients and you can see a tumor that looks like esophageal cancer, try to take 6 to 8 bites rather than less than that, because that increases your yield. You can dilate and stent the patient at the same time. Now, staging CT scan, as I mentioned, this will be a contextualized approach. Locally, it's used selectively only. Whereas a lot of cancers, all patients will get staged with a scan, and mostly with a CT scan. It's not true for esophageal cancer in our local context in this public sector. Other investigations that are mentioned in international guidelines include bronchoscopy, endoscopic ultrasound, PET scan, staging laparoscopy are used even more selectively. This is the staging system that is used currently for esophageal cancer. It's a TNM classification. Now, it's not a difficult classification to learn. However, if you have to learn a lot of staging classifications for lots of cancers, then you want to simplify this. And this whole staging system can be simplified. But the thing that I want to make note of here, since we have the laser esophageal wall displayed here, you can see that the esophageal wall has got a mucosa, submucosa, muscularis propria, and then there is no serosa, only an adventitia. Adventitia is very soft, flimsy little tissue, hardly anything to write home about. The other thing is that most of the esophagus is in the mediastinum, which is a confined space with lots of major organs around it. So for these reasons, by the time the patient's got dysphagia, you've got local advanced disease, because as the tumor grows in the lumen, the esophagus just simply expands to allow food to pass, and the patient does not experience dysphagia to the extent that they need to go to a doctor for. Then, as the tumor grows through the laser esophageal wall, it easily grips onto tissue surrounding it, and some of it cannot be removed en masse with the tumor. And that's why this makes this tumor so difficult to treat. And I will show later on what percentage of patients you can actually remove the tumor for. But as I was mentioning before, you can simplify the staging system. So TNM, we know the T stands for tumor, and the T1 tumors usually goes up to the submucosa. Is an early stage cancer. That's what we call early esophageal cancer, or you can call it stage 1. Any other T stage, including up to T4B, where it invades surrounding structures that cannot be removed, and lymph node involvement, is considered locally advanced disease, and that's stages 2 and 3. And then anything metastatic, obviously, is stage 4. So you just have to remember early, locally advanced, or metastatic. If you remember those and you follow international guidelines, okay, they will give you a very complicated algorithm and workflow on how to manage these patients. If you simplify it, as I have done here, it will tell you that if it's early, you need to excise it. And you can excise it via endoscopically or with an esophagectomy. Locally advanced tumors requires multimodal management. Now, while esophagectomy may or may not be part of it, of this management, chemoradiotherapy or chemotherapy are two different modalities that are part of the treatment of locally advanced. And the chemoradiotherapy can be given as neoadjuvant or definitive, in other words, without surgery at all, while the chemotherapy is usually given perioperatively, like as for gastric cancer. Metastatic disease in esophageal cancer, unlike some other cancers, has to be treated palliatively. There's no way that they can be treated curatively. But the palliative treatment is also can be complex according to the guidelines. It includes stenting, it can include radiotherapy, which can be intraluminal or external beam, and or chemotherapy. Amongst all this treatment for both locally advanced and metastatic, immunotherapy is coming into the fore with immune checkpoint inhibitors that have made gained a lot of ground, made a lot of ground with managing these patients, both palliatively and curatively. However, these are very expensive drugs that are not so easily available. So I would then like to propose a contextualized approach to these patients. And the way we manage our patients is we look at all factors that influence how we're going to choose our management. And of all the factors, there are many. These are the main ones that we look at. We look at the patient's performance status and some clinical factors. The histological subtype determines where you're going to go. The stage of the tumor, yes, is important, and then the resources. However, you can't take any of these in isolation. What you should do is you should combine the information you get from all these things and make a multidisciplinary team a decision on what eventually you're going to do with the patient. So it can seem complex, but it's quite simple. For example, if you get a patient with a locally advanced tumor, so we know now the stages could be early, locally advanced, or metastatic, and it happens to be resectable, so it can be removed. There's nothing that says it can't be removed. And squamous cell carcinoma, well, that is most of our patients, 90% globally, probably 95% locally. And say the patient's performance status is 1. In other words, they can actually perform work activity. They're just a little bit limited by the fact that they have this disease, and they got a normal BMI and adequate resources. In other words, there's no real resource constraints. Then this patient will get chemoradiotherapy. And this will be with or without surgery. And the surgery, it depends on where you are. People do different things. So some people will follow all neoadjuvant chemoradiotherapy with surgery. Some people will do it surgery as needed, and some people will do definitive chemoradiotherapy. And some cancers that are very proximal cannot be removed surgically, and so they get definitive chemoradiotherapy. The point is that these patients all will get chemoradiotherapy, and then surgery may be part of that algorithm. On the other hand, say you've got the same tumor, SCC, and the same ECOG status, but you've got a long waiting time for radiotherapy. Now that I'm using as an example because of a resource constraint, because that's actually the one that we experienced here locally at Gray's Hospital. My head of oncology told me that if I want neoadjuvant chemoradiotherapy for a patient, I'll have to wait 6 months to start the radiotherapy. And as we know, that will probably be too late for the patient, because by that time, the patient would have wasted away from the symptoms itself of esophageal cancer. So yeah, you can't give the treatment as per international guidelines. So for example, this patient, you would given your resource constraints, you do upfront surgery for this patient because it's resectable. So you can resect it, remove the tumor, and then the patient may get adjuvant chemoradiotherapy depending on the results of the surgery of whether lymph nodes are involved or the stage of the tumor, the pathological stage. So you can see you have to adapt, and you have to adapt because of the resource changes. Another example means is like, say you got a locally advanced and resectable tumor, that's SCC once again, and you got adequate resources, but like the patient I presented, the ECOG is now 2, so this patient cannot do any work activities, including working around the house. The BMI is 17, so it's underweight patient that has lost a lot of weight, and the albumin happened to be 24, which is considered a severe hyperalbuminemia and increase your risk of complications. You can see that trying to do an esophagectomy on this patient would be a dangerous undertaking, and chemoradiotherapy is unlikely to be tolerated by this patient. So this patient would receive palliative care, even though they got a locally advanced and resectable tumor. They simply will not tolerate the treatment required to give curative management. Now, given that international guidelines and the local contextual guidelines, you can see globally, 40% of patients only are cured. Now, this is if you take all esophageal cancers from all parts of the world, and 60% are palliated. What do you think the situation looks like locally? Well, I can tell you locally in our area, which is area 2, we only get to treat 5% for cure, and 95% get palliated. So the reason for that is that patients are coming late. And when they come late, it doesn't mean that they got an advanced stage. It means they come late and they are too weak for treatment. That is what's happening. Why are they coming late? We looked at it and we found that the timeline looks like this. There's a delay in dysphagia onset for esophageal cancer due to the expansive nature of the esophagus, which I explained, which is a universal concept. But the problem is from there, locally, we find that patients wait 5 months before they present anywhere because they fail to recognize that dysphagia means they've got a cancer, and the family fails to recognize it as an alarm symptom. We've got an uncomplaining culture, usually elderly patients. The grandparents in the house, they do not want to bother their children, and they don't say they've got dysphagia. But after a while, the family notices the weight loss and brings the patient to a healthcare center. The problem is that there's still another delay of 3 months before referral. And that's because the healthcare system now fails these patients. And most of my patients tell me that they were treated for ulcers for a full 3 months or more before they get referred. And from there, once they get referred for a scope and you see the tumor, it's still another 1 to 2 months delay, depending on where you are, to get histology and plan your treatment and get theater time, etc. So you can see through all this time, the tumor is growing, the patient's wasting away because they're not eating and not taking orally. And this is the reason why we can only treat 5% of our patients for cure. This is just the situation in area 2 of KZN. I don't know, it may be different in other areas, but I wouldn't be surprised if it's similar. This is the point that we can make a difference, and we should try to, where we as healthcare workers improve our recognition of the alarm symptoms. So, and in South Africa, in general, we found that patients with esophageal cancer are usually subjected to just an eyeball test. People will tell you even that they are performing, they're doing a performance status assessment, but they're actually just eyeballing the patient. And often this eyeball is done by an endoscopist. So the patient is coming through a busy endoscopy list. You really don't have time to talk to the patient and ask them, can they do work activities at home? Are they in bed? How long? You just eyeball the patient because, like I said, you've got a busy endoscopy list. Patients that fail the eyeball test and you've seen the cancer often gets palliated there and then because you don't know if the patient will come back to you. Only patients that pass the eyeball test might get referred for a CT scan, and if that shows it to be resectable, it may be sent for surgery or chemo radiotherapy, depending on where you are. But often you find them irresectable. They may then still be able to get radical radiotherapy if it's available, or they get palliated, as in our case, where radical radiotherapy is hard to come by. This, for us, is 90 to 95% of our patients, so way too many. Can we do better than the eyeball test? We can. We can do a prognostic score for patients. We have published on this, and we found that we developed a prognostic score based on just 3 parameters. The BMI, the albumin, and the ECOG, which we came by looking at which factors affected our patient survival. We found that when we made a score, we weighted them differently. When we made a score, it correlated well with prognosis, and we managed to come up with this proposed management algorithm that clinicians could use instead of just eyeballing a patient. They can decide whether, if the patient got a low prognostic score, you can say that, well, no, the chances of survival probability is low and surviving less than 3 months is less than 50%. And you can then decide that this patient is better off being palliated well, rather than being subjected to many stage investigations that will just show anyway that they can't tolerate treatment anyway. But you did little more than just eyeball the patient. Okay, once you've decided what to do, you can follow certain treatment principles. Like I mentioned, a multidisciplinary team approach is important. It's ideal. You decide whether it's curative or palliative early, and it's based on a number of things. Try to avoid the eyeball test. But the performance status is more, an ability to tolerate treatment is central to this. The staging CT you'd perform if there's potential for cure or palliative radiotherapy. Try to use prognostic scores. There are international ones, but they're not always applicable locally. In other words, they don't use parameters that we got access to easily. And sometimes they require staging CT, which a locally developed prognostic score does not, and it's easier to use and cheaper. If you're going to decide to cure patients, then there must be no clinical criteria for palliation. So in other words, and the ECOG has to be no more than one, really, with no comorbidities that are prohibitive. And then the stage will determine then what you do: endoscopic, surgical, chemoradiotherapy, or definitive chemoradiotherapy. And the histological subtype also determines what you give. But the majority of patients we are treating palliatively. So how do you do palliative care? Well, you must remember that what your aims are. You want to relieve symptoms, yes, but you want to improve quality of life. It's better to do this in MDT setting. In other words, more than one person with a different discipline should try to make the decision together with you, rather than one person eyeballing the patient but sitting on your endoscopy in your endoscopy list in your endoscopy room. Remember, when you give best supportive care, that it requires a number of things. It means relieving suffering, realistic discussions about the diagnosis and prognosis with your patient, evaluating the expectations and providing psychosocial support. Involve family, friends, and caregivers in this whole process if you're giving palliative care. Palliation of dysphagia itself can be done in a number of ways. So serial dilatation is one. It's simple and inexpensive and readily available. We use these separate dilators usually, but it's temporary only. You have to at least within 2 weeks redilate them. There's a perforation risk, and they're not recommended as sole modality because we don't sure how this doesn't really improve patient's quality of life by that much. Stents are great. They do improve quality of life quite a lot, quite effective, rapid relief, and good for fistulae, but they can have complications and they do cost more than 10,000 Rand for a stent that we see. External beam radiotherapy is also pretty good, effective, and good for high tumors that you can't stent, but they're toxic and resource constraints is a problem. If you can wait 6 months, that's too long for a patient to palliate. Brachytherapy is a very well-known, highly effective modality that improves quality of life, but it's complex and availability is not so great. Don't forget, you can combine some of the treatments like stenting and external beam radiotherapy depending on individual patients. Okay, other symptoms can be palliated include pain, which is multifactorial and subjective. Morphine should be part of it because it gives the patient also a sense of well-being. Nausea and vomiting, you must exclude mechanical obstruction before treating, but aldosterone is good for treatment-related nausea and vomiting. And then treat the reflux-related symptoms with PPIs, with prokinetics if needed. There's no real benefit with anti-reflux stents. Malnutrition is a big problem for these patients because a lot of them come to you because the family brings them because they're worried about the patients wasting away. It significantly impacts the quality of life as well. This is exacerbated in our context with poverty. If you relieve the dysphagia and give nutritional supplementation, then it usually can help to stem the tide of this wasting away. But feeding tubes are used in some centers. They are controversial. Personally and locally, we don't really use them for our patients. Don't forget the psychosocial support. So then I'll finish off with just algorithms. The dysphagia algorithm should say dysphagia equals upper endoscopy. And you must try to get your patient as soon as possible to somewhere where they can scope the patient. I know locally we use a Vula app on our phone. Just on your phone, you can send a referral very quickly. You can see it looks like this, and you can see we've got a dysphagia referral at Gray's Hospital, just to try to get patients a bit earlier where I'm on call for most of the time. And the picture on the right shows my colleagues that are also there. So these patients can be referred quite early and expedited. When we do endoscopy and diagnose when you do the endoscopy, you can either find a normal study, tumor, or other pathology. In a normal study, in a patient with dysphagia, you should treat it as a dyspepsia. If the patient's symptoms, they may resolve or persist. If they persist, if they resolve, then you can just follow them up. But if they persist, you should refer that patient because now you've got someone with dysphagia with a normal endoscopy study. Refer them so we can find out what's causing it. Other pathology should be treated and the tumor should be referred. Once we've diagnosed esophageal cancer histologically, we first assess the patient's fitness and his prognosis. Now, like I said before, eyeball test was done, but you can now also do a prognostic score. If the patient's got a poor prognosis, then they can be palliated. Palliated dysphagia, best supportive care, don't forget it. Patients with good prognosis can be staged, and if there they can decide if it's advanced, they can be palliated, or they can be for cure, one of the two. So it is the algorithm they follow, which is quite simple. So in conclusion, it's common and fatal in KZN, and as you can see, 95% of patients got SCC, and 95% are treated palliatively. Late presentation is the major problem, so systemic failure of the healthcare system does play a role, and we can improve that. Population-based education is important. Risk factors I haven't got into for time, but alarm symptoms, we have to try to educate our people. What are alarm symptoms? Healthcare workers should also be educated about healthcare systems and algorithms, and we should try to improve referral patterns. There are expedited referrals for dysphagia in our area, just so that everybody knows. The management principles are in a multidisciplinary team always. Fitness and performance status is the key. And try to do a prognostic assessment before you stage the patient, so you don't do unnecessary staging investigations. And curative management, it's it's complex, but resource dependent and multimodal. Palliative management is the treatment of dysphagia, improvement of quality of life, and best supportive care, like I mentioned. And just to finally, our patient had come, we saw her 1 month after her stint, and she had no any dysphagia at the time, but she did have some reflux symptoms with mild body pain she complained of. But her ECOG had improved, so she could do some work at home, but her weight stayed the same. But she was feeling better overall, which is usually the best we can ask from this palliative management of our patients. Thank you.
Okay, thank you, Dr. Van Dale, for a really insightful presentation. I'd like to add. Dr. Govender, would you like to facilitate the discussion amongst the participants?
Thank you, Sarila. Thank you, Mr. Van Dale, for that overview. It's a very sobering presentation, and it's hard to stay optimistic about esophageal cancer. I'm just going to open the floor up to questions or comments. You can raise your hand or type it in the chat box. But while I'm waiting for that, is it safe to say that one of the problems with esophageal cancer, especially in an academic environment, is that the trainees have to know what the literature says and what international guidelines say, but the practical management in a resource-constrained environment is completely different?
Yeah, I think that's a good way to put it, and that's why the approach I showed here is takes these key things into consideration when deciding. But if you read the international guidelines, like say the NCCN guidelines, they will never put it that way. They will say you stage all your patients, and then you give them treatment according to stage. And they talk about extensive neoadjuvant therapy. They talk about immunotherapy, all these kind of things, and we simply don't have access to those things. So therefore, it's better to have also a practical approach in your back pocket.
I see a hand up. I think it's Prof. Pagati.
Yes, no, thank you very much, Lucian, for an insightful talk. And thank you so much also, Mogi, for facilitating this session. Great talk indeed. And Mr. Fended, you did also mention that you did not cover the risk factors. And actually, I was more interested in knowing about the risk factors because we're not sure who of the participants might not be aware of that. Obviously, for the surgeons, they may know. What is it that the patient, what are the risk factors, and what is it that the patient can do in order to avoid getting the esophageal cancer? Thank you.
So firstly, before I actually answer the question, I have to say that the literature on the risk factors for esophageal cancer in African patients is not good. A lot of the literature comes from either Asia or high-income countries like America or the Americas or Western Europe. So you can't really extrapolate that to our patients. That's first of all. However, you have to know what's out there, what's written out there as risk factors. And then it depends on whether it's squamous cell carcinoma or whether it is adenocarcinoma. And in squamous cell carcinoma, the established risk factors are smoking and alcohol, which appear to work synergistically. There's nutritional deficiencies, certain micronutrients that are deficient in the diet, that are considered risk factors. There is polycyclic aromatic hydrocarbons, which come from, say, indoor fire, smoke, etc. All these things and drinking hot drinks, etc., have all been shown to increase your risk of esophageal cancer. For adenocarcinoma, it is basically a patient like the gastroesophageal reflux disease, Barrett's esophagus complex of disease that they get, together with obesity. That usually gives you risk factors for adenocarcinoma, which I said, remember, that's usually a disease of high-income countries. The problem with the squamous cell carcinoma risk factors that I mentioned is that one, you'll find that a lot of female patients that get it, and about 50% of our patients are female, don't smoke or drink alcohol. Two, you'll find this exposure to this indoor fire, combustion, etc., is ubiquitous in our country, in our rural areas, and across Africa. And not all the patients are getting esophageal cancer. So we're not even sure if that is the case. And then three is you can see this distinctive geographical pattern, which tells us it's something more than that. It must be actually something maybe in the soil itself, or a genetic component that we absolutely have no idea what it is. So it's very complicated, but those are the ones that are established and written about. Just keep in mind that they don't necessarily apply to our patients.
No, I'm glad that you mentioned it. Thank you so much. I'm not sure why now I'm written as Sarala Ramtlas, but I'll take it for a day. Yes, and I also like the fact that you mentioned that now you're seeing like women who are also non-drinkers, because I know years back it used to be seen among black men who tends to consume a lot of traditional beer. But I'm glad that this is your area that I mean, just your research area of interest, and we're hoping to see more and more of these questions answered later on. Thank you so much.
We have a question in the chat from Dr. Vasanthan Pillay. Dr. Pillay is making me feel very old because he's now a surgeon, but he was once my intern. And his question is, or his comment is, thank you, Mr. Vandel, for an excellent presentation. And the question is there any role for TPN use in, say, esophagus, perhaps as a bridge while awaiting stenting or dilatation?
Okay, thanks for that. So, yeah, if you're going to ask, if you say TPN in, say, esophagus now alone, then remember, if you're going to treat a patient curatively, let's go there first before I answer that specific last part of your question. Then TPN can be used post-surgery for patients. If you perform an esophagectomy on a patient as part of his curative treatment, then TPN is often used as post-operative feeding in patients. And yes, there it has an established role. As an alternative to enteral feeding, if enteral feeding is not possible for some reason, for whatever reason, or if it's choice of the institution. When it comes to, when you say perhaps as a bridge for stenting dilatation, I assume then you mean for palliatively treated patients. And then the answer, there's not an easy answer to that one. The problem with using TPN and why we would not use it is because of the expense, simply because of the expense. And weighing up whether it's a cost-effective measure to feed a patient who is going to be treated palliatively and whose survival is not that long is a decision that you have to make based on your available resources, etc. I know where we are working, we wouldn't give it because our resources do not allow for it. It's too expensive a modality. And all these patients really need is, although the malnutrition gives them a problem, what they need is to be able to swallow again so that they can start gaining the nutrition back with enteral feeding and actual oral feeding if possible. So we must try our best to get there as soon as possible. Hopefully the stenting and dilatation should not be so long a wait that TPN will make a difference, because TPN usually, as I say, in general, its indication is if you expect a long period that you're going to wait to institute enteral feeding. And hopefully, if you know that the patient can't swallow anything, you will be intervening before that time. So personally, I would say probably not.
Thanks, Mr. Vandel. We've got a raised hand from Dr. Amna Yasir. You can go ahead, Dr. Yasir.
Hello. It was a great presentation. Thank you for all of the information. I have a question about the risk factors. In my country, we had an extremely rare case of a pediatric esophageal squamous cell carcinoma, and we couldn't figure out why it happened. I'm a very junior doctor, and when we tried to reflect the risk factors because he was so young, nothing matched. And when we looked in the literature, we couldn't find anything related. So I wanted to highlight that it is true. I am from an African country myself. I'm from Sudan. I wanted to highlight that it is really neglected in the literature and African cases, and especially pediatric cases. I think the youngest ever published was 14 or 15, maybe. So I wanted to hear your insight about that. What do you think could be the cause?
Okay, so I don't know anything about esophageal cancer in pediatric patients. I have to say it outset. Now, like I mentioned when I was answering the question for that Dr. Pagade asked what risk factors is that we simply don't know because we've got this very interesting geographical distribution of the high incidence area. Why is Western Africa not plagued by esophageal cancer? We actually don't know. We've tried to find out, so we don't know. Are you, if I can just ask you a question, Dr. Yassir, are you familiar, you're part of the African Esophageal Cancer Consortium?
No, I'm extremely young. I just finished my internship,
Okay.
but
Okay. So,
yeah.
yeah, so now the reason I was going to ask is because, so there's a organization in Africa called the African Esophageal Cancer Consortium.
Mhm.
And what we've got, it's a big organization, and one of the branches is an etiological working group that is working basically 24/7 on trying to find out why patients in Africa are getting esophageal cancer, what are the risk factors, etc. And they are dedicated to finding out what is the cause of esophageal cancer. And up to now, they have not found out. So
Oh,
basically, yeah, the short answer is we don't know.
thank you, though. Thank you so much.
Sure.
We've got a few questions on the chat line. The first is from Dr. Nduduzo Madondo. Is there a role for routine screening in endemic areas?
Okay, so the answer to that is yes. I didn't touch on screening at all because of the time. So we had a limited time, but definitely there is a role in endemic areas. What you have to do though is first of all, you have to establish which areas are endemic. Like, even though we know it's on the east coast of Africa, it's not the whole of the east coast of Africa. You'll find there are pockets of hotspots. So you're going to have to actually go to those areas. So the problems with screening at the moment is for esophageal squamous cell carcinoma, the only established screening method that has been proven and used is endoscopic. So which means that you have to go to an area that's high risk, academic area, as you mentioned, and then you have to go and scope all patients that are in that area. So that is a highly invasive screening modality. In addition, you have to still stain the esophagus with glucose iodine, or you have to use a very advanced narrowband imaging to try to see areas that you're going to biopsy, etc. So it's both expensive and invasive, labor intensive, etc. So therefore, it's not actually being used anywhere in Africa at the moment. Screening has been used or is being used in areas in China with great success. But that is because they found a very high incidence areas and they managed to make it cost effective there. To make it cost effective in Africa, we first have to do the baseline work and find out where are we going to go and what are we going to do. The other thing about screening that I just want to mention, since it's been asked, is that there's a different modality to screen for adenocarcinoma. You don't have to do endoscopy. Adenocarcinoma also got a cytosponge screening method, where patients swallow a pill, which then opens up in your stomach and becomes a sponge, or the sponge comes out. The capsule comes off and the sponge comes out, and then they draw the sponge out with a string, and then they have certain stains that can look for cells that are indicative of adenocarcinoma. So this screening has been performed in high-risk patients with, like I said, gastroesophageal reflux disease, Barrett's esophagus complex, and obese patients, and they found that has made a difference in finding them early. But for squamous cell carcinoma, only endoscopic, Lugol's iodine staining or narrowband imaging is the only ones that have been shown, and only in areas in China. But yes, there is a role for screening.
Thanks, Lucien. We've got another question from a surgeon here, Dr. Amal Singh, who also said thank you for an excellent presentation. And he asks, what is the role of a barium swallow before endoscopy? Should it be routine to exclude tufts or other pathology that mimic esophageal tumors?
Okay, so the answer is no. And the answer to the first part is that there's no role for barium swallow. So if you look at all international guidelines on management of esophageal cancer, so you say you take NCCN, which by the way is American, so obviously they combine adenocarcinoma as well. But you can also take ESMO guidelines, which is Europe, which is European. Chinese have their own guidelines, and Japanese have guidelines on esophageal cancer. And I've read them all, and none of them mention a barium swallow as part of their workup. So in international guidelines, there is no role according to the literature. Personally, from our side, we don't use barium swallow either. The problems with barium swallow is, one, you can't establish a diagnosis. You need the scope and the biopsy anyway. And if you follow the dictum that dysphagia equals endoscopy, then you will make your diagnosis without a barium swallow. You can diagnose the TOF at barium swallow endoscopy. You don't need a barium swallow for it. And the other problem with barium swallow is if it's done in close proximity to or a short time period before the scope, then it inhibits your vision of the scope and it can damage your scope. So you might have to delay the scope, and you don't want to delay the scope in someone's dysphagia. Dysphagia equals endoscopy, should be a take-home message. And I would say there is no role currently for barium swallow.
Thanks, Lucien. Another question from Dr. Goodwill Dube. Can one attempt esophageal dilatation blindly in a resource-constrained environment?
Okay, yes. So, yeah, yes, you can. Esophageal dilatation blindly. Yes, the answer is yes, you can. So the safest way to do it, to perform it, if I can explain, it's better to show, but I'll try to explain it, is the way we teach endoscopists to do it as part of the organization I was mentioning earlier on, which is the African Esophageal Cancer Consortium. Another branch is a clinical working group that goes around and tries to teach endoscopy and stenting and dilatation for patients with esophageal cancer. And the safest way to do it is that way. So the way we do it is, if you scope a patient and you find that you cannot pass the tumor itself, then you should pass a long, soft wire, typically used for ERCP wire, which is a hydrophilic wire with a soft tip that cannot perforate mucosa of anything because it's a soft tip wire. You use that wire to pass the tumor. If you need to measure the wire. So as you put the wire through the channel of the scope and you reach the top of the tumor, you have to measure from the biopsy channel opening 40 centimeters outside your scope itself. And you must be able to move your wire 40 centimeters in from the point that you measured till your biopsy cap, so that you know that distally the wire has moved 40 centimeters. Once it has moved 40 centimeters and it's gone easy, so you didn't feel any resistance, then it is safe then to dilate over that wire. That's the safest way to do it that we teach. Like I said, I'm explaining it now, but it's probably better. I wouldn't advise you try it without somebody showing you. And I'm happy to show anybody who wants to, if they just contact me, and I'll be happy to arrange something so we can show you how to do it. But it is the way to do it. And most places in Africa are resource constrained and cannot use screening. So we all use without fluoroscopy. I must say that here at Grace Hospital, we don't use the soft wire tip, but it's because we have experienced endoscopists doing it. And so we use a savory wire, but that, like I said, I only advise it if you've got experience with it. Otherwise, the safe way is to use a soft wire tip that is almost impossible to perforate with.
Thanks, Lucien. I don't see any further questions or comments. We've still got a few minutes more if anyone has any burning questions. But perhaps while you're waiting, I can make a comment and then just ask your take on it. The practical decisions we make on a daily basis about patients with esophageal cancer are based on those four things you mentioned and ultimately based on our resources. And a lot of the times it's not consistent with the guidelines. So I think it's very important that we don't make these decisions in isolation, and it should be part of an MDT. Your thoughts?
Yeah, no, I agree completely. I think even if you're going to decide to treat a patient palliatively, like I said, the practical way it's done nowadays is the endoscopist just eyeballs the patient and say, "There's no way this patient's going to tolerate surgery, so I'm going to stent the patient or dilate the patient," and that's it. Whereas that is definitely not endorsed by any guidelines. So what I would recommend is a multidisciplinary team approach and try to use validated prognostic scoring methods, and there are many available. But definitely the more the merrier when you're making a decision. Yeah, no, I agree.
I have a raised hand. I'm not sure if it's from the real Cyrilla or the fake one.
Go on.
It's me. Dr. Govender, it's me. All right. Dr. Fandel, I sit here and I'm thinking, gosh, there's so much work to be done in Africa on esophageal cancer. And I think this is really a fertile area for research. For instance, should we all be moving to West Africa where there's no real threat of esophageal cancers, for instance? I just want to just add, just in terms of the technique you've described on esophageal dilation, if you have a video and if you could share that video with me, then we can upload that video of the technique onto the site, and so more people can have access to the technique if you're happy to do that. So the other question I have is, I'm a primary healthcare advocate, so I'm always asking, how can we translate this knowledge to the healthcare practitioners at primary healthcare clinics within our communities? Okay, so for instance, what then would be an early warning sign, and what would their referral pathway be for primary healthcare nurses, for instance, to actually quickly identify or suspect that this could be esophageal cancer? And, what would then the referral pathway be? What should be an alarm bell for people working at primary healthcare clinics? And then I just want to ask one other question. You just sparked my interest. The other is related to, you mentioned that the patients don't, they seem to have difficulty with tasks around the home. Are there any particular tasks or just activities of daily living that then would also ring an alarm bell?
Okay, so yes, for the performance status, we ask about any task that they can perform. So if they can't perform any task, usually it means that they can't even clean around the house or work in the garden, and etc. So that's the task we're talking about. It's not tasks that require any heavy lifting or anything like that, just simple basic tasks. And that just tells you that their performance status is in such a place that they really won't tolerate much in terms of treatment. That was that one. The other question we asked about early warning signs is there are none. If the patient has got the dysphagia, which is the symptom that almost everybody with esophageal cancer present with, then it's already late, so it's not early. However, if you go, say, for example, in another part of the world, then you'll find that patients present with dysphagia and immediately get diagnosed. While it's not early, it's not as late as with us. So with us, what happens is the patient gets dysphagia, goes to get help and gets told to take some treatment and come back if it doesn't improve, which what I've tried, that's the thing we need to change. What we need to change, and this is happening usually from listening to my patients and from the research we did, it's happening at primary healthcare centers. So it's either at the clinic or it's at the district level hospital. where the patient is coming with a symptom of dysphagia and they are told that it's probably ulcers, it's probably reflux acid, and take this treatment and then come back. And it's usually a PPI they're given. So that is what we need to change. When the patient says there's a problem swallowing, they should definitely have a scope. So that's the one thing they can do. And like I said, it won't be early, but it'll be earlier than we're getting now. Because worldwide, 40% of patients can still get cured, which is not a big number, but locally only 5%. So that is a dismal number. So we just definitely need to improve that. And then the other thing is, if yes, I'm happy to share the technique and literature on it, but I'll also be happy if you share my email address and number, and anybody can contact me if they want any help. I'm happy to help them.
Oh, wow. Thank you. Thank you so much. This has really been insightful. I'm just wondering how then can we move this knowledge to primary healthcare centers? What would be, we really need to advance our education efforts at that level. So, if we're wanting to sort of turn the tide on late referrals and, just in any event, just reducing the time from diagnosis to intervention. So maybe that's something we can look at next year as a follow-up to this. I think there's enough. There's so many questions, Mr. Fandale, that that require answers to. Dr. Govinda, are there any other comments? Any other questions? I'm so excited about the presentation. Sorry, I'm not for. Yeah, sorry. Go ahead.
No, there's no other questions on the chat line, just lots of thank yous for an insightful talk. And I want to say thank you to Project ECHO and to Mr. Fandale as well. We are both very passionate about esophageal cancer, and I think we're both hoping to make an impact in our lifetime. Raising awareness is the first step. Encouraging research is the next step. And I think ultimately developing our own guidelines will be the final step. So thank you very much.
Wonderful, wonderful. Thank you so much, Dr. Govinda. Well said. Dr. Fandale, last words?
No, nothing more from me. Thank you. I said enough. Thank you very much.
Prof. Pakati, last words from you, maybe closing comment.
No, just to thank you for extending the invitation to the Department of Surgery, and also to thank my colleagues, Mr. Fandale as well as Ms. Govinda, for a well facilitated ECHO session. We look forward to a follow up on this in the near future. And like you mentioned that yes, raising awareness about this is actually like one of the biggest steps in diagnosing the disease earlier on and ensuring that the patient gets the right care. That's all from my side. Thank you so much, colleagues.
All right. So thank you. So thank you, everybody. And just for me to say thank you to thank you to the hub members and to the Department of Surgery for sharing this wisdom with us today. Dr. Ferndale, your presentation was really remarkable. Thank you. Thank you, Dr. Govinda, for facilitating the session so beautifully as well. I'd like to also extend our thanks to the ECHO India team for the technical support and to the College of Health Sciences IT support team, as well as to the School of Medicine administration team for their assistance with the dissemination of the adverts. And in particular, I'd like to say thank you to Prof. Glover, who actually initiated this project of online outreach with the University of New Mexico, and for providing us this platform to share our specialist knowledge to all of our healthcare workers in the province and beyond. And we thank you very much to the doctor from Sudan who actually joined us. So just to say that the advert actually goes out to all of Africa as well, not just KZN. So thank you very much. And we look forward to our next session in the series from the Department of Surgery, which will be on snake bites. So look out for that advert. Colleagues, thank you very much and have a good afternoon.
Thank you. Bye-bye.
Thank you. Bye.